Good afternoon to everyone here. I am honored and excited to stand before you at the Global Conference 2025 and Inti International University in Malaysia. My name is Ponelavaras from Sri Venkateshwara College of Physiotherapy in Kobi City Palayam, Erode, and affiliate with Dr. MGR Medical University, Tamil Nadu in India. Before getting into the topic, I am big thank for giving the opportunity in Inti International University in Malaysia. Title of my presentation is Inspiratory Threshold Loading combined with Tilt Training, Enhancing Baroreceptor Sensitivity in Postural Orthostatic Tachycardic Patients. Let's start with introduction. Postural orthostatic tachycardic syndrome, it is the common form of autonomic dysregulation. It is mainly seen in premenopausal women aged 18 to 45 years. And then patient usually complains of like fatigue and syncopal and dizziness as well as sleep disturbance. Main mechanism began to the postural orthostatic tachycardia, impaired of baroreceptor reflex sensitivity, it affect the cardiovascular control. To avoid this, we used the inspiratory threshold training. It is a form of inspiratory training. It enhances the baroreceptor sensitivity and improve the vagal tone. And another part, it is a tilt training. It enhancing orthostatic tolerance to standing by training the baroreceptor. And then we use both effect is a very effective and non-pharmacological approach of postural orthostatic tachycardia syndrome. It is the management. Next, we can see aim and objective of the study is. Aim of the study is to find out the effect of inspiratory threshold loading combined with tilt training on baroreceptor reflex sensitivity in patient diagnosed with postural orthostatic tachycardic syndrome. And then objective of the study is to evaluate the changes in baroreceptor reflex sensitivity by giving tilt training and inspiratory threshold training patient with orthostatic tachycardic syndrome. Let's talk about hypothesis of our study. Null hypothesis. There is no significant effect of inspiratory threshold loading combined with tilt training in postural orthostatic tachycardic patient. And then alternative hypothesis is there is significant effect of inspiratory threshold loading combined with tilt training in postural orthostatic tachycardic patient. Let me explain with methodology used in our study. First of all, study design. Our study design follow in experimental study design, and then study population. The patient is diagnosed with postural orthostatic tachycardic syndrome, and then study setting. Research was conducted in KMCH Erode Department of Cardiorespiratory Physiotherapy. And then sampling technique, I was included in conventional sampling technique to select our participants. And then sample size, the sample size included in 30 postural orthostatic tachycardic patients. And then study duration is, the study was conducted over a period of 6 months and treatment duration is period of 8 weeks and patient allocated in the both groups. Next, we can see the selection criteria. First of all, inclusion criteria. I included the participants age in 18 to 45 years were diagnosed with neuropathic parts and defined as increasing the heart rate more than 30 beats per minute within the 10 minutes of active standing and without drop in significant blood pressure. And then all participants occur to hemodynamically stable at the time of enrollment. And then additionally, who those able to perform inspiratory threshold training and tilt training were included. And to avoid the confounding variables, anyone who had joined to the structured rehabilitation program, especially in the autonomic focus, that could be excluded in our study because of it could affecting my study outcome. Then another hand, our exclusion criteria. Participants were excluded. They had known case of cardiac arrhythmia or structural heart disease. Also excluded those with severe anemia or uncontrolled thyroid disorders or any other orthopedic or neurological condition that limiting upright posture and inspiratory threshold training. Then patient on beta blockers or any other drugs that affecting the autonomic tone in started with the last 2 weeks, they are excluded. And then I eliminate the pharmacological interference that the patient also have severe autonomic failure or any recent head injury related syncope in the last 1 month. And pregnant women, I was excluded our study because of hemodynamically risk for the my study. Next, we can see the variables of the study. First of all, in the independent variable, inspiratory threshold loading and tilt training. Then dependent variable, the baroreceptor sensitivity. And then we can see the group allocation. I was allocated in the both groups, group A and group B. Then experimental group, I was included the 15 members. I was provided the inspiratory threshold loading and tilt training. Then group B is control group. I was included in 15 members and I was provided the conventional physiotherapy. And then study outcome, changes in baroreceptor sensitivity. Then outcome measures, active stand test, pulse oximetry and sphygmomanometer. These three tools I was used in my study. Then statistical tool I was used in the padded t-test and unpadded t-test because of within group analysis and between group analysis of my study calculation. Then we seen in methodology, especially in the intervention protocol, our study. Let me explain with intervention therapies. First of all, I divide in the both groups, intervention group and control group. The intervention group underwent the two therapies, tilt training and combined with inspiratory threshold loading. For start with inspiratory threshold loading, I was used with the dedicated inspiratory threshold trainer device, and then initial load set at the 30% of the participant's maximum inspiratory capacity, and then breathing pattern is slow deep inhalation breathing pattern and followed by the passive exhalation. And then the session is started in the 15 minutes per day, and then the progressive was increased the week by week, and then based on the individual tolerance. In another part for the tilt training, the tilt angle is maintained 60 to 70 degree and head up. Initially started with the 15 minutes and progressively go with up to 30 minutes over the week. And then treatment frequency is 3 to 5 times per week. And our studies say the main discontinuation criteria for this intervention, participants who feel any severe dizziness or syncope or any other sustained tachycardia above the heart rate in 130 beat per minute, and if there any oxygen saturation below the 90 percentage or any other respiratory discomfort, or if the patient is voluntarily stopped to the intervention, I can immediately stop my session. And then we can see the control group. The control group, I was provide the conventional physiotherapy like lower limb strengthening and semi-recommend positioning for duration of 8 weeks. Next, these are my data analysis of the study. These are the demographical data analysis. Next, we can see the within group analysis of the group A and group B for baroreceptor sensitivity. First of all, you can see the pre-test value 6.27 and post-test value is 9.28. This is biggest improvement in group A in after application of my intervention. Then we can see the group B, it is pre-test value is 6.33 and post-test value is 6.50. This is the very little amount improvement in application of conventional physiotherapy in the control group. Next, we can see the between group analysis of the post and post mean value of baroreceptor sensitivity. You can see the group A 9.28 and group B is 6.50, and the statistical value, the level is less than 0.001, especially in the p value. Next, we can see the graphical representation. These are the left side are the within group analysis of the group A and group B of the baroreceptor sensitivity, and then right side between group analysis of the group A and group B. It is the indicate is very highly improvement in after our intervention is application. Next, we can see the result and discussion. The statistical analysis showed that there is significant improvement in the both groups, but comparing the post value of the both groups, group A has a significant improvement than group B. The level of significance in p values less than 0.001. Based on the findings, the alternative hypotheses were accepted and null hypotheses were rejected, confirming that the combined both approach direct and measurable effect of the improved the autonomic regulation as well in the vagal tone and orthostatic tolerance. Then from clinical standpoint, the experimental group show the greater improvement in the baroreceptor sensitivity compared to the control group. It is the key factor for regulating the blood pressure and heart rate during the postural changes. The improvement is not only for statistically, it also translated to the functionally. It is the better control like symptoms, dizziness and fatigue, as well as sleep disturbance. It also decreased to the postural orthostatic tachycardic patients in after application of my intervention. And then next we move on conclusion. To conclude it, our study is highly demonstrated to the greater improvement in baroreceptor sensitivity and vagal tone in after application of my intervention in the experimental group, and compared to the control group, my intervention is the greater improvement in postural orthostatic tachycardic syndrome. And then we move on limitation and future scope. I do acknowledge a few limitations in our study. First of all, the study sample size was very small that affect our study generalizability. Secondly, heterogeneity among the patients. The term of heterogeneity is age, gender and any other comorbidities that may influence our study outcome. And thirdly, the study was conducted over a period of 8 weeks. And then these not could assess the long-term sustainability of my intervention. And finally, hence I recommended that future research could be conducted over long periods and very many comparative protocols and longer follow periods. Then finally, by targeting the both autonomic regulation and cardiorespiratory endurance, this dual approach could offer the both enhancing baroreceptor sensitivity and improve the vagal tone, as well increasing the orthostatic tolerance, especially in the postural orthostatic tachycardic syndrome patients. Then I really believe the study is newly open in venue in evidence-based physiotherapy intervention in control the autonomic disorders like postural orthostatic tachycardic syndrome. And these are my reference of the study. The reference of the study used in my this research. And